Hi, I am Radhakrishna Menon, Vice President, Content Development Training and Conferences, National Association of Palliative Care for Ayush and Integrative Medicine. I would like to present before you a session presented by Dr. Sadhana, Assistant Vice President, Punjab State Chapter, National Association of Palliative Care for Ayush and Integrative Medicine. Nursing care, oral care, NGT feeding, catheter care. Mouth care is an essential aspect of palliative care in all settings and should be considered part of daily routine patient care. Oral complications resulting from cancer and its therapy can cause both acute mucositis, saliva changes, taste alterations, infection and bleeding, and late toxicities, mucosal xerostomia, oral candidiasis, oral thrush. This is the candida infection of the oral mucosa, commonly seen in immunocompromised patients and as sequelae of head and neck radiation therapy. This leads to varying degrees of pain and difficulty in swallowing. These lesions can be easily removed. Chronic or hyperplastic, chronic erythematous, or occur as angular cheilitis. Treatment: nystatin liquid 1 to 2 ml 4 hourly, mucostatin lozenges, clotrimazole mouth paint. Management of chronic candidiasis usually requires much longer treatment and may require oral ketoconazole, fluconazole 150 mg daily for 7 to 14 days or intravenous amphotericin B. Home remedies for oral candidiasis. Some of the home remedies are garlic, honey, coconut scrapings, table salt and ice cream. Because of antiseptic effect, clove and betel leaves are also used with some benefit in oral candidiasis. This is an age-old practice, but there is no textbook evidence. Xerostomia or dry mouth. Xerostomia is a dryness of the mouth and subjectively reported by the patient. It often leads to oral discomfort, difficulty in swallowing and speech, and also contributes to caries producing organism. Causes: drugs, antimuscarinics, antidepressants, opioids, diuretics, etc. Dehydration, radiation therapy, mouth breathing, oxygen therapy, non-humidified, candidiasis, anxiety. Management: keep mouth as moist as possible with frequent sips of water and semi-frozen drinks. Treat the underlying cause. Review medications. Basic oral care regimen. Artificial saliva with carbohydroxylcellulose as base, though expensive, has not been demonstrated to increase the oral cavity comfort. Avoid use of tobacco and alcohol. Home remedies: sucking ice cubes, cut and frozen pineapple pieces. Pineapple contains a mouth cleansing enzyme, also a salivary stimulant, however it is acidic. Salted lime pickle, chewing gum, sugar free and sour flavor hot candies. Application of ghee, butter, margarine, swishing vegetable oil around the mouth 3 to 4 times a day. Stomatitis or sore mouth. Stomatitis refers to the painful inflammatory, infective, infiltrative and ulcerative condition affecting the mucous membranes lining the mouth. This results in areas of asymptomatic redness and erythema. This gradually progresses from solitary white elevated desquamatic patches which are slightly painful to contact pressure to large contagious pseudomembranous painful lesions. This results in dysphagia, and decreased oral intake. Causes of stomatitis: infection, Candida albicans, bacteria, herpes simplex; ulceration, malignant and non-malignant ulcers and tumors; mucositis, post-radiotherapy and chemotherapy; iron deficiency, angular stomatitis and glossitis; vitamin C deficiency, dry mouth. Management: general measures: good oral hygiene, frequent sips of water and semi-frozen drinks, chewing pineapple pieces and sugar-free chewing gum, application of petroleum jelly and vegetable oil, consider saliva substitutes, avoid acidic foods, tobacco and alcohol. Specific measures: treat the underlying cause if possible, example infection; dental, ENT and oncologic review. Drug management: local anesthetics, xylocaine jelly 2% or 4% viscous, choline salicylate gel, sucralfate, silver nitrate. Homemade mouthwash solution used in Sudarshana Palliative Care Center, Trichy. Sudarshana oil mix: mix the following ingredients in 1 liter of warm water: 1 tablespoon of common salt, 5 ml of providine iodine solution regular mouthwash, 3 ml of hydrogen peroxide solution, 1 200 mg tablet of metronidazole crushed, 2 mint units from example Polorol, 1 to 2 cloves. The following are optional. If the lesions are painful, to add 4% xylocaine viscous up to 10 ml for every 1 liter of the prepared solution. If suspected fungal lesions, add 1 tablet of fluconazole 150 mg. Sudarshana mix can be used 3-4 times a day, can be used regularly in oral care for chronically bedridden patients. Halitosis: halitosis means unpleasant and foul smelling breath from oral cavity. Causes: oral causes: poor orodental hygiene, dental caries, gingivitis, malignant ulcers and growths; severe infection and necrosis along with sepsis in the oral and nasal passages; sinusitis, malignant growths in the sinuses; suppurative drug-like diseases; perceived halitosis, the person experiences halitosis but cannot be detected by others. Management: frequent mouthwash with Sudarshana oral mix, metronidazole gargle, systemic course of metronidazole may be required, appropriate use of antibiotics if infection is present. Abnormal taste: irrespective of the primary site, patients with advanced cancer experience a change in taste sensation. There may be a general reduction in sensitivity of taste or a specific reduction or increase in sensitivity of taste. Abnormal taste sensation is made worse by poor oral hygiene, oral candidiasis, and among those who have reduced sense of smell, a common problem among elderly. Management: improve oral hygiene, treat oral candidiasis, modify diet, use of pickles, salt, lemon juice, vinegar to overcome poor taste. Include more fruits in diet, drink more water, to add or reduce sugar as per the patient's wish, to reduce eggs, dairy products, use of cold or warm food as per the patient's wish. Drooling of saliva and siluria: patients may produce excess saliva. Patients may also have difficulty handling normally produced saliva because of alterations in mouth anatomy or because of impaired neurologic control of the swallowing reflex. Drooling carries a great social stigma and can be very disturbing to patients and families. Patients with Parkinson's disease, Hemotropic lateral sclerosis, cerebral vascular accidents, dementia and developmental disorders are prone to this. Patients in the very advanced stages of dying may also experience difficulties as they lose their swallowing and cough reflexes. Usually, the underlying cause is untreatable. However, anticholinergic agents can be of some help in decreasing salivary flow. Care should be taken in using systematically absorbable agents as they can produce troubling side effects. In addition, for some patients, the dry mouth that results from medication may be as troubling as the earlier drooling. Glycopyrrolate may be effective in decreasing salivary production with little if any systemic toxicity. Glycopyrrolate is an anticholinergic agent that is poorly absorbed from the G1 tract and that minimally crosses the blood-brain barrier if given systematically. Tablets of 1 mg can be dissolved in a small amount of water and held in the mouth or swabbed into mucosa if unable to be held and then spit out. This is usually given BID or TID is swallowed. Glycopyrrolate will have a strong local anticholinergic effect on the GI tract and decrease motility and secretion into the gut. This will worsen constipation or treat diarrhea, but decrease the systemic effect as only 5% of the drug is absorbed. As the goal of therapy is to reduce the production of saliva, not to dry the mouth completely, the mouth should be moistened with artificial saliva if secondary xerostomia results. Nursing care of the patient with a nasogastric tube. Nasogastric tubes are typically used for decompression of the stomach in the setting of intestinal obstruction or ileus, but can also be used to administer nutrition or medication to patients who are unable to tolerate oral intake. Provide good oral hygiene at regular and frequent intervals. Offer water or mouthwash to rinse the mouth every hour. Assist the patient to brush his teeth at least every 4 hours. Keep the nostrils free of accumulations of dried secretions. If permissible, apply lubricants such as Vaseline to the lips and nostrils for the patient's comfort. Encourage the patient to swallow saliva naturally. The tube is a constant source of annoyance and the patients may have a tendency to expectorate excessively. The physician may allow chewing gum or hard candy to help maintain mouth moisture and to encourage normal swallowing of saliva. Only cautious, responsive, alert patients should be given these items. Caution: remind the patient to remove gum or candy before mouth care and sleep. Report complaints and signs of nose or throat irritation, excessive mucus, sore throat or hoarseness. Encourage the patient to change position frequently, using care not to pull on the tube and not to lie on the drainage tubing. Follow diet orders exactly. If water or clear fluids are allowed by mouth, be sure to check on amount to be given at one time. Know exactly whether or not the tube is to be clamped when fluids are given and at what time interval in relation to oral intake. For example, the order may be to clamp the drainage tube for 1 hour after intake to allow some absorption. Keep accurate intake and output records. Large amounts of fluid and electrolytes are lost during continuous suction drainage. Observe the patient frequently when he is asleep, noting the tube marking at the nostril. The patient may have unknowingly pulled the tube out partially or completely. If partially out, advance the tube to the required point and check for drainage. Tape securely. If the tube has been accidentally removed, notify the nurse or doctor. Reinsert only on order. Therapeutic indications for NG intubation. Gastric decompression, including maintenance of a decompressed state after endotracheal intubation, often via the oropharynx, relief of symptoms and bowel rest in the setting of small bowel obstruction, aspiration of gastric content from recent ingestion of toxic material, administration of medication, feeding, bowel irrigation, following corrosive ingestion for the development of a tract in the esophagus that subsequently can be used for balloon dilatation. Nasogastric tubes may be placed for nutritional support while waiting to see how much function the patient will recover, and if the patient does not recover their swallowing ability or will otherwise require long term nutritional support, then a more permanent feeding tube should be placed, such as gastrostomy or jejunostomy feeding tube. Complications. The most complications related to the placement of nasogastric tubes are discomfort, sinusitis or epistaxis, all of which typically resolve spontaneously with the removal of the nasogastric tube. NG tube feeding is a safe procedure, however, it could be misplaced when it is being inserted and may enter the lung, or the tube could be displaced once it is inserted. Displacement is when the tube moves out of the stomach because of coughing vigorously or vomiting, or the tube may have slipped for other reasons. Displacement can happen anytime, but the risks are reduced by routinely checking that the tube is in the correct place. Prolonged use of NG tube can cause irritation to the gastric lining, causing GI bleeding. Patients with extensive irrigation with an NG tube can develop electrolyte abnormalities such as hypokalemia. There are certain questions that are answered. Patients with palliative care needs are particularly at risk of oral problems. Enumerate the reasons. List the general measures of managing oral thrush. What are the causes of halitosis? How do you manage it? What are therapeutic indications for nasogastric intubation? Enumerate the steps for catheter care. So, there are certain references like the IAPC for Indian Association of Palliative Care textbook for certificate course in Essentials of Palliative Care 5th edition, and there are other books also as can be taken for references. Thank you.